Hello runners, David McHenry, physical therapist and the director of our Therapeutic Associates Biomechanics Lab. Today is the third installment of our six-part series that we are calling Biomechanical Minutes. And today we're dealing with knee pain. But before we dove into the biomechanics, I wanted to answer a couple of questions that have been coming through as we've been pushing out the first and the second installment of this series. The first question is, once you know the biomechanical dysfunctions, can you jump right into treatment? And the answer is no. Just because we know that something exists doesn't mean that we know why it exists. In order for us to know why it exists, we have to go through a two-part evaluative process. The part that we're spending all of our time with is the biomechanical evaluation. That's what the whole six-part series is revolving around. What we're not talking about is the clinical evaluation. That is imperative. So when we're looking at this two-part process, the clinical evaluation normally comes first, and that's where us as physical therapists get you as patients, runners, clients within our clinic, and we do a full evaluation looking at muscle function, joint function, flexibility, motor control, all these different things. And once we get to the end of that, then all of the information that we get about your joint function, flexibility, your strength, your motor control, your neurology, your proprioception, your tissue integrity, etc., this list can go on forever. This really informs us as to why we find what we find biomechanically. So that when we go into the biomechanical evaluation, once we can actually see the dysfunction, we can trace it back to the clinical evaluation to figure out why you have the biomechanical dysfunction and therefore how we need to fix it and correct it. So the important thing after this two-part process is the information that we get from the clinical evaluation and the information that we get from the biomechanical evaluation have a lot of overlap, and they're telling a very similar narrative. So that's the answer to the first question. We need to do this in order to really understand the biomechanical evaluation that we're going through in this six-part series. The second question that I want to answer is, can these biomechanical faults be fixed? Which is a great question. And the answer is, yes, they can, as long as we go through this process. Again, just because we know that there's a biomechanical dysfunction doesn't let us know why there is a dysfunction unless we've gone through this process as well. So everything that we're pointing out in these biomechanical evaluations or these biomechanical minute series are things that we've had a lot of success improving as long as we've gone through the two-part process. So what does that look like? Very simple example. Runner comes in with knee pain, and we go through a clinical evaluation so we know what's going on in the body. We do the biomechanical evaluation and we find some of the biomechanical dysfunctions that we're going to talk about here in just about 30 seconds. So we know that they have an increase in a valgus collapse, so the knee is diving inwards during midstance. We know that they have a lot of hip adduction. These are all things that we're going to be covering here momentarily. And we know that those are biomechanical precursors to knee pain. From the clinical evaluation, we know that the foot ankle looks really strong, really stable, the joint is very solid. So we know that the knee dysfunction is not coming from the foot up. However, in the clinical evaluation, we find that there's a lot of weakness and inhibition in some of the muscles in the back of the hip that control the femur orientation. And because those things are potentially weak or inhibited, is going to create a destabilization of the femur, cause some of the biomechanical variables that we're going to see here in about 30 seconds, driving the knee dysfunction. So the pain is in the knee, the dysfunction is in the hip, so the treatment strategy has to involve the things in the hip that we found during the clinical evaluation that inform us as to why the biomechanical finding is what it is. Last question is, what research are you using? And we actually use a lot of research. There are dozens and dozens of articles out there that are showing biomechanical variables that correlate highly to injury predisposition. One article in particular that I like to lean on quite a bit is out of the University of Salford over in Great Britain, and it's called, Is There a Pathological Gait Associated with Common Soft Tissue Running Injuries? Very easy read, very good read, and there's probably a dozen different biomechanical variables that we're using in these biomechanical minutes that really correlate highly with injury. Great research. So we will try to put a link to this within this video somehow. We'll see if my media guy can somehow magically do that. And if you want to read it, pull it off, read it. It's a great read. All right, that's it. Let's dive into the biomechanics.
All right, so diving into the biomechanics. Today, looking at knee pain in runners, which is a very common pathology that a lot of runners get. We see a lot of runners with knee pain in our clinics all the time. So this is very common, and it's something that we spend a lot of time kind of evaluating and working with. So today we're going to look at 4 different biomechanical variables that we know have a significant correlation to developing overuse knee symptomology. And we are going to use our very own Lindsay Provencio, physical therapy superstar, and my partner in crime. Her and I did the 6-week strength and conditioning program that we pushed out over the course of 2020, the year of COVID. And we pointed out a lot of her weaknesses and inflexibilities, and she was a great sport the entire time. Today we're going to use her to look at her biomechanics, and she actually does have left knee pain. And she told me earlier today that the knee is particularly sore over the last couple of weeks. So we have a real patient with real left knee pain, and she has almost all 4 of the biomechanical variables that increase likelihood of developing that knee pain. So we are going to dive in. And we are going to first look at the frontal plane. And 3 of the 4 variables happen in this plane during mid-stance, which is where we get peak vertical force into the ground. So we're going to go past the right knee and we're going to come to the left knee. And the 3 variables we're going to look at are knee varus valgus angle. So we're looking at how much the knee bows in or bows out during mid-stance. We're going to look at the hip adduction angle, which is the angle between the pelvis, which is this green line, and the femoral bisection, which is this red line. And we're going to look at contralateral pelvis drop, which is the manifestation of the opposite side of the pelvis dropping down a little bit in relationship to the loading leg as we go into mid-stance. We'll explain that a little bit more when we get to it. So we're going to keep our eye here on the knee varus valgus angle. Right now it's 179 degrees, so that's 1 degree away from perfectly vertical. So she's 1 degree of valgus. So we're going to go forward and we're going to see that her knee goes all the way into about 9 degrees of a valgus position. We don't want to see more than 5 degrees of knee valgus during mid-stance. She is at 9 degrees. That is quite a bit higher than what we think is the high end of normal. So this is the first thing that we like to look at. And in Lindsay's case, she has a big red flag right there, excessive knee valgus at mid-stance. If we come up into the hip and we're looking at the hip adduction angle, we know from research, and specifically from the research out of the University of Salford that I pointed out at the beginning of this video, that we don't want to see more than 13 degrees of hip adduction collapse at mid-stance. And Lindsay is at about 14 degrees, which is 1 degree more than the high end or the high range of what we think is healthy. So that's another red flag for Lindsay, 14 degrees. And if we go to the next slide, we'll actually see that there are times that she gets even higher. So now she's at 15 degrees of a hip adduction collapse. Knee still at 9 degrees of a valgus collapse. So red flag there, hip adduction, red flag there, knee valgus. And now we're going to look at the contralateral pelvic drop. So during mid-stance, and in this case, Lindsay's on the left leg, we know that we get a little bit of a contralateral pelvic drop. So the other side of the pelvis, the right side of Lindsay's pelvis, is going to drop down a little bit in relationship to the pelvis, the side of the pelvis on the loaded leg. University of Salford, the researchers out there tell us that anything more than 5 degrees of a contralateral pelvic drop significantly increases likelihood of lower extremity injuries, including overuse knee pathology. So Lindsay's right at 5 degrees. I don't think she goes more than 5 degrees. So that's probably a yellow flag, but she's really approaching having 3 red flags right off the bat. Okay, the next variable, the 4th and final variable, we're going to look at in the sagittal plane. And we're going to look at initial contact. That's the phase that this biomechanical variable occurs in. So this looks like we're getting close to initial contact, but we want to be very specific. So we're going to go back and look at our pressure plate. And we're going to progress forward until we see the first presence of pressure. There it is. So this is where Lindsay makes initial contact on that left leg. We're going to go back to the left side, and we're going to look at her knee angle at initial contact. So right now, Lindsay's at 6 degrees of knee flexion at initial contact. And what we know is that anything less than 6 degrees, 6 degrees or less actually, increases likelihood of pathology. And Lindsay's right there at 6 degrees, right at initial contact. Now, as we go forward, the knee will start to flex, but that happens with everybody. But for Lindsay, when she makes initial contact, the knee is a little bit too straight, which is going to change some of the force attenuation through her leg, which is going to increase some of that injury potential in that left knee. So there you go, short and sweet, 4 biomechanical variables, 3 in mid-stance in the frontal plane with the hip adduction angle, the contralateral pelvic drop, and the knee valgus angle, and then the 4th in the sagittal plane with excessive knee extension at initial contact. So there you go. That is it. for this installment. That one was pretty short and pretty sweet. Thank you all for watching. Thanks for all the comments. Thanks for all the questions. Keep your eye out for the fourth installment that will come out next Monday. And if you have any questions, then feel free to ask us. Ask us in the comments section, send us an email, and we will do our best to answer all questions that come through.